Hi everybody, I'm Shailesh representing Team IHP AI Innovation. We're representing Inland Empire Health Plan based out of Rancho Cucamonga in California. We serve about 1.5 million Medicaid members. With that being said, let me get right into it. Imagine if Netflix only recommended the movies you watched last year and guessing your next pick from that same stale list. Would you pay $25 a month? Probably not. Now imagine your care is managed the same way, with outdated lists and late nudges. Healthcare has always been playing catch up. We built a multi layered, AI enabled HEDIS care gap platform that flips the model from chase and close to predict and prevent. You might be wondering, what is HEDIS? So, quick context, HEDIS is the healthcare effectiveness data and information set that measures quality of care for health plans. Think colorectal cancer screening, cervical cancer screening, bell child visits, and these are tracked yearly or on a different time period based on that quality measure. Health plans get paid millions in quality bonuses for hitting these targets. Miss them, you lose money, and members don't get the preventive care they need. And HEDIS is important because it drives up the quality of care and in turn improves patient health outcomes. Now, let me make it real with one member's story. Meet Sarah Johnson. Her colorectal cancer screening, or COL, was due on November the 17th. In today's workflow, a care coordinator gets a Q task, manually reviews the charts, chases calls between the member, the PCP, the specialist. That cycle can average sometimes up to 45 days. Now, as you can see, from each of the audit logs from the care management system we use, Sarah completed the screening after the due date. For COL, that is non-compliant for that particular measure year. HEDIS measures improve quality, but they can be operationally very heavy. The member often learns about a gap, or the provider or the care coordinator, they do learn about that gap after it's due. With HL7 FHIR standardizing the data pipes, and with AI on top, we can surface near real time insights before the deadlines slip. Now, enter our platform. Our HEDIS platform starts with HEDIS but generalizes to any pay for performance measure. It ingests HL7 FHIR R4 or FHIR R4 data and unstructured evidence like PDFs and care management notes. We have a Gen AI extraction layer that turns free text into structured proof of compliance, and a predictive layer that flags members at most risk of future noncompliance. Therefore, outreach is focused and fewer calls are needed. Now, if I can speak about the data sources for a real quick minute here, we have made the solution to be input agnostic. Being a health plan and having access to multiple data sources, we're able to take raw HL7 messages, whether they come in MDM, ORU, or ADTs, or FHIR R4 JSON bundles from CDAs or otherwise transformed at the HIE or the Health Information Exchange. In case there is a direct connect for large hospital systems that use EMRs like Epic and Cerner, we also have the ability to take that kind of data in. We also have to we aggregate claims for pharmacy, labs, medications, especially for our layer 2, which predicts the risk of noncompliance. Now let me walk you through this dashboard really quick. We're processing about 1260 synthetic members across 3 HEDIS measures. Only 12 are shown on this dashboard. There's about a 95.3% automated evidence identification rate. That's our Gen AI extraction working. More on that a little bit later once I walk you through the dashboards and the front end demo. The platform found structured evidence for 9 members, and if you click on this filter, let's say you're a care coordinator coming in, you can actually look at all the members for which care gaps were automatically found from their base 64 embedded PDF documents in the raw HL7 messages or FHIR bundles. Now, if you do click on a member, we can actually look at the layer 1, the evidence extraction engine, that a cervical cancer screening was overdue. Last pap smear was 2022. Patient is scheduled for a screening appointment next week. And the risk factors and protective factors from the XGBoost uh, risk prediction for non-compliance layer is actually shown right here. The care coordinator can choose to text patient alerts or send appointment reminders. And if the gap is closed and the evidence of the appointment is taken, the care gap is automatically closed. Now, keep in mind that given that we have a lot of members and it is IHP data, we have generated synthetic members for the purposes of this demo. Now, moving on, let's say now the high risk case. We pass in the PDFs are extracted by our HL7 processing service. The NER plus RAG pipeline doesn't find evidence for which it has happened for, let's say, about 5 members. We're only showing 2 in the synthetic demo. But this, if you click on this, you quickly filter down to high-risk patients.